Hi all. This is the Improving Health System Performance Through Economic Planning and Post-Implementation Evaluation of Health Services webinar. We're just waiting 1 minute for participants to join. If you could just be patient, we will start the webinar very soon. Welcome to others that have just joined. We are just waiting for others and we will start in the next half minute. Okay, so let's start the webinar. Welcome to this webinar on evaluating health services. I'm Professor Henry Cutler. I'm the director of the Centre for the Health Economy at Macquarie University. I'll be moderating this webinar today, which will be an extremely interesting webinar. You're in the right place. Throughout the process, please submit your questions and comments during the course of the presentations. We do encourage dialogue. We'll address as many questions as possible during the discussion at the end as well. Next slide, please. I'd like to acknowledge the traditional custodians of the land from which all participants are joining and pay my respects to their elders past and present and emerging. I would like to extend that respect to all Aboriginal and Torres Strait Islander people with us today. Next slide. So I'd like to begin with a brief introduction of the Partnership Centre for the Health System Sustainability. The NHMRC Partnership Centre for Health System Sustainability, or PCHSS, is a $10.75 million 5-year collaboration involving 17 lead investigators, 20 expert advisors and over 40 system implementation partners from around Australia. Next slide. The PCHSS is a national grant. As you can see on the map, the investigators and system partners span all Australian states and territories and work in many different sectors, including academia, public health and hospitals, private health, health insurance, government, not-for-profit healthcare, and consumer advocacy. The PCHSS is guided by an international advisory group and a scientific advisory committee and is overseen by a governance authority comprising representatives of the NHMRC and each funding partner. Next slide, please. The vision of the PCHSS is to produce research that contributes to the development of a resilient healthcare system, one that is affordable, cost-effective, and delivers improved health outcomes for all Australians. Next slide. The purpose of the PCHSS is to generate and disseminate ideas and evidence to improve the performance of the healthcare system so that it delivers care efficiently and effectively over the long term. We seek to maximise healthcare system improvement in the real world by bringing together people who provide, plan and need healthcare. Next slide. The PCHSS has 3 main research themes which address different aspects of healthcare system sustainability, and the Observatory on Health System Sustainability, which focuses on system evaluation and system change, as well as managing the Partnership Centre. The Analytics, Technology and Shared Data theme tackles important questions in informatics and healthcare, including using big data to improve care, diagnostic testing and medication management, as well as designing analytics to guide better decisions in healthcare. Researchers are also examining how telehealth might be best deployed and funded to improve healthcare across the country. The Reducing Waste and Low Value Care theme focuses on finding ways to reduce wasteful or low value care, which accounts for 30% of all healthcare, and to deliver needed care more efficiently. The Better Value for the Health Dollar theme covers 4 major areas, using financial incentives to promote value-based healthcare, priority setting and decision-making in healthcare organisations, the impact of markets, competition and choice in healthcare, and the impact of a collaborative research program on cost savings and efficiencies in healthcare settings. While the Observatory on Health System Sustainability conducts research on factors that affect the sustainability of health systems nationally and internationally. The observatory team also coordinates engagement with investigators, stakeholders and funders, and facilitates the wide dissemination and translation of all PCHSS research outcomes. Next slide, please. As you can see, over the last 3 years, our network of collaborators has grown substantially, reflecting the importance and impact of the PCHSS research. So that concludes our brief introduction to the PCHSS. Before we welcoming our main speakers, I'd like to note that this is the 4th in a series of 6 webinars that the PCHSS is hosting until May this year. The April webinar on evaluating implemented health services will be held next month, and it will discuss the impact of payment methods on healthcare providers. It will feature Professor Anthony Scott of Melbourne University and will be moderated by Associate Professor Yvonne Zirinsky. Further details about this webinar, as well as a registration page, will be made available at a later date. And now, turning to the focus of today's webinar, improving health system performance through the economic planning and post-implementation evaluation of health services. To begin, Professor Jon Karnon will discuss the Embedded Economist program, which links economists with healthcare managers and clinicians to evaluate local health services. Professor Karnon leads the PCHSS priority setting and decision-making in healthcare organisations research stream. He is a health economist at Flinders University who has been developing and applying methods for the economic evaluation of health technologies and services for almost 25 years. He is past president of the Health Services Research Association of Australia and New Zealand and has been a member of the economic subcommittee of the PBAC since 2009. He is leading the South Australian node of the Embedded Economist project, developing and applying processes for the use of health economics in a local health service. Over to you, Jon.
Thanks very much, Henry, for that introduction. I've just realised as you're talking, I've just ticked over 25 years. So it's just before it was, when I wrote that, it must have been just coming up to 25. Now it's just ticked over. So I'm going to talk about the work we've been doing as part of the Partnership Centre, which is, as Henry said, focused on using or undertaking and using local economic evaluation to inform decision-making and prioritisation. I'd just like to start by also acknowledging the country on which I'm providing this webinar, which is the lands of the Kaurna Nation, and acknowledge that they're traditional owners and custodians of the land, and pay my respects to their leaders past, present and emerging. So this is part of the NHMRC Partnership Centre in Health System Sustainability, but I also just wanted to note that as a result of our involvement in the Partnership Centre, we've also become part of the Embedded Economist project, which is funded through the MRFF, but through 2 of the translation centres, so New South Wales Regional Health Partners and Health Translation SA. And my third and final acknowledgement slide is to acknowledge that this is clearly a team effort, what I'll be talking about today, and my colleagues here at Flinders University have been undertaking most of the work that I'll be talking about today, but also to acknowledge all of the fantastic collaborators within Southern Adelaide Local Health Network, SALHN, which I'll be referring to frequently. Too many to name, but the key people at the top, and then the teams we've been working with at the bottom there. So in this presentation, I'm going to just provide a brief background around what I would describe as the differences between health system economic evaluation, which in Australia is essentially evaluations undertaken to inform the funding of new health technologies, and local health service economic evaluation. But then the focus will be on 3 case study economic evaluations that we're at various stages of completion with, working with SALHN. So to start with, just putting economic evaluation in Australia in context, most economic evaluation is undertaken around new health technologies to inform decisions made by both the pharmaceutical benefits and the medical services advisory committees. And they're in a really unique situation where economic evaluations of new drugs, new medical services are presented to these committees, and they make decisions about whether the benefits justify the additional costs. And it ought to be said that in almost all cases there are additional costs. And when they're making those decisions, there's an implicit assumption that some form of lower value healthcare currently being provided will be identified and stopped or reduced in order to free up the resources that are required to fund these typically more expensive new health technologies. And that's very different to the decision-making context in local health services, where there are real budget constraints on the decisions that are made by local health services. But also to note, and I won't go into the detail, that the costs from a health system perspective are very different to costs from a local health service perspective. So if we're talking about hospital health services, clearly they're not incurring costs associated with primary care, for example. And so that introduces some complexities into the conduct of economic evaluation from a local health service perspective. Another key difference is around the evidence, or the quality of the evidence available to inform economic evaluations. So in the health technology context, most clearly illustrated when we're looking at new pharmaceuticals, there's usually, not always the case, but usually good quality, large randomized controlled trials available to inform an economic evaluation. So as an example, we may be PBAC, maybe evaluating new drug A. There's a multinational trial comparing drug A versus drug C to give really robust evidence on the effectiveness of the new drug. And when translating that evidence to an Australian context, there may be alternative scenarios. So in the best scenario, drug C is the current practice for the indicated patient group, in which case, we would typically apply the trial outcomes directly to estimate the costs and benefits in Australia. In other cases, the drug used in the trial may be different to current practice. So drug C was used in the trial, but drug B is used in practice. But we've got mechanisms for handling those situations. We can use an indirect comparison. So we can identify a trial with a similar patient population that evaluated drug B, and we can make an indirect comparison using the results from trial 1 and trial 2, as illustrated in the diagram. In a health service perspective, undertaking economic evaluation, we may again have some evidence on the effectiveness of a new service here. New service A was evaluated in 3 hospitals in Sydney. But from a South or Southern Adelaide perspective, maybe service C, which was the comparator in the trial, is not implemented. That's not current practice. Rather, some alternative service B is implemented. What are the mechanisms for estimating the effects of service A in SALHN, given this difference? Well, much less likely to be able to undertake an indirect comparison, because there's unlikely to be a trial that evaluated service B in a similar set of patients to those used in the randomized controlled trial evidence. And so it's a lot more uncertainty around the evidence to inform local economic evaluations. And we can think about how we might use evidence in the terms of a spectrum. So at one end of the spectrum, we could say, okay, well, we've got this trial that's evaluating a service that we think is potentially relevant to Southern Adelaide. We'll just assume that it's going to have the same effect in SALHN as it was observed to have in Sydney. At the other end of the spectrum, we may say, oh, well, there's completely different context. The Sydney hospitals, they've got different current practice. We're just going to ignore that evidence, and we'll develop our own intervention. So what we're trying to move towards is is trying to identify the most relevant point on the spectrum for different service evaluations. So within the spectrum, we can use other published evidence, we can use local data, and we can use local knowledge, stakeholder knowledge and experience to inform our economic evaluation. And where we land on the spectrum will vary from evaluation to evaluation, but that's really what we're trying to investigate is how do we incorporate all of these sources of evidence to inform local decision making. So just to make an explicit statement about what we're addressing. So local economic evaluation can be undertaken both to assess the value of potential services that we're looking to inform decisions about their design and whether to implement them. But we can also undertake economic evaluations of existing services. And so those evaluations can inform a whole range of decisions around which new services should be implemented. But then with respect to existing services, which maybe have value in expanding, which maybe should be contracted to some degree, and which maybe should be completely de-implemented. There's other options available for managing certain patient cohorts. Also to note that these issues are not new. These are all Australian studies that investigated the use of economic evaluation in local health services. You can see, going back to 1995, there was a call for researchers to be more responsive to local decision makers. 2011, building on that, referring to the need for economic evaluation to reflect the local context. And then most recently in 2015, acknowledgement that the time and the cost required to conduct economic evaluations can be a barrier, but also knowledge around how to interpret economic evaluations is seen as a barrier. So we're trying to address all of those barriers and build on facilitators. But I guess the take home really is that we're trying to establish methods for economic evaluation that are as simple as possible, but as the great man said, not simpler. So moving on to our first case study that I'll talk you through is focusing on a pre-implementation decision. So here the catalyst for this study was that SALHN, as are every hospital network in Australia, are being penalised financially for the occurrence of hospital-acquired complications. So we identified with our SALHN colleagues hospital-acquired hypoglycemic events, mainly experienced by diabetic patients, as an important target area for SALHN. So the general structure of this evaluation was to put together a working group. You can see here that involved the SALHN hospital-acquired complications coordinator, as well as a pharmacist, endocrinologist, and nurse representatives in the working group. And so the first steps were to undertake a clinical audit of patients who are experiencing hypoglycemic events within hospital to understand what types of patients and what was leading or contributing to the experience of these events, alongside a literature review of evaluated interventions that targeted the prevention of hypoglycemia in hospital. And the working group provided great support in terms of both designing and the conduct of the audit, as well as informing the design of the literature review. The next stage, we synthesized, brought together the audit data and the review data and put it into a format to present to the working group so that they could select which interventions they thought were most relevant from a SALHN perspective. And then the final stage is the economic evaluation, which we'll be presenting to the SALHN executive tomorrow. So this slide is just an illustration of the information of how we put together the information from the literature review and the audit to inform the selection of relevant interventions. So you can see here we're describing the study type, the setting, some information on the intervention, but also importantly the prerequisites. So here the prerequisite was that there's an electronic medical record that was recording the relevant blood glucose level tests directly into the EMR, as well as some measure of carbohydrate intake. So you may think, oh, well, that's pretty obvious, but we're still checking whether that's going to be possible in SALHN, where EMR has actually only just been rolled out in the last month or so. The intervention itself was a virtual glucose management service involving endocrinologists, nurses, and pharmacists, who essentially reviewed automated reports of patients at risk of a hypoglycemic or hyperglycemic event. And you can see that significant effects were observed, both in terms of reducing hypoglycemia as well as hyperglycemia. And then the final bit of the table is relating it to the population. So from the audit, we estimated that around 60% of patients experiencing a hypoglycemic event would have been picked up by the automated report. So that kind of gives some local context to interpreting the effects of this intervention. So from that process, 3 potential interventions were identified, the VGMS being the middle one there. And so at this point, we're at the stage of estimating the resources that would be required to implement the different interventions. And so you can see the top one there is probably going to require the most resources. So in the study, in a 300-bed hospital, 2 full-time pharmacists were assigned to the intervention. Flinders Medical Center, the main SALHN hospital, is actually a 600-bed hospital. So that's going to be potentially 4 full-time pharmacists to implement that intervention, which we estimate will reduce the number of hypoglycemic hospital-acquired complications by 36. So there'll be the patient outcome improvements associated with that, as well as the reduction in financial penalties. The VGMS system requires much fewer resources, from basically reviewing the automated reports, providing notes in the EMR, which are then reviewed on morning rounds. Slightly less effective is our prediction, but it'll be interesting to see how the SALHN executive respond to this information. Case study 2 is around an intervention that was implemented really as more of a pilot within the Flinders Medical Center, that was looking at supporting quality assertive discharge, so the SQUAD intervention, and the catalyst for that was to reduce long stay inpatient admissions. We started by developing a process map to understand the pathways that long stay inpatients were taking through the hospital. And that was combined with the experience and the knowledge that had been generated through the pilot study. So the pilot study, limited scope for as I say here, robust statistical evaluation, but certainly provided a good qualitative understanding of both the issues, but also potential solutions in terms of potentially moving patients between different pathways to improve their pathway through the hospital, but also to improve their experience of care along the pathways that they're experiencing. And so what we're doing here is looking at those different pathways, and this is just an example of some of the data we're putting together. I should say this is Andrew Partington, who's been leading the work on this, and Jody Gray was leading the work on the hypoglycemics. So here we're describing the distribution of lengths of stay for patients going down different pathways to inform our stakeholders around the potential to move patients, but improve patients with respect to reducing the tails, essentially, of those distributions. We've got additional data on funding. So you can see here, this is the funds received for the care of these patients minus the costs. And so you can see that there's a negative funding gap for all of these pathways that we've identified. So again, we can take this into consideration when designing the subsequent intervention. And so this is towards the end of the spectrum where we're relying more on local knowledge and local data, but also incorporating published evidence where possible. But we'll be essentially trying to elicit values from stakeholders with experience in this area around which pathways could be improved to reduce length of stay, and which pathways is the potential to move patients between in order to improve pathways through the hospital whilst maintaining or preferably improving patient outcomes. The third case study is of an existing service, and this was, this is the extended scope of practice use of physiotherapists in the emergency departments. And here, obviously, the capacity of the ED was the catalyst for this evaluation. And so the initial data to inform this was some analysis we did that showed that the probability of admission for what we defined as lower severity fracture ED presentations reduced significantly according to the number of patients in the ED at the time of presentation. So this highlighted the potential for or evidence of variation essentially in admission practices, which led to investigation of this use of extended scope of practice physios. And the existing evidence certainly suggests that physios in ED are potentially more efficient in terms of managing the patients using fewer resources, whilst demonstrating at least as effective as usual medical care for pain reduction and reducing disability. And there's some Australian evidence to back up this as well. So our analysis of the local data, we undertook a matched and regression-based analysis of ED presentations that were managed by an extended scope of practice physiotherapist compared to those managed by an ED physician. And you see we identified very significant outcome effects, an odds ratio of 0.49. So essentially you're half as likely to be admitted to an inpatient bed if you're seen by a physio as compared to an ED physician, and 1.2, so 1.25 hours less time in the ED if you're seen by a physiotherapist. Noting that this is observational data, so there may be scope to inform decision making further, perhaps using a clinical audit to increase confidence in those data. So converting those data into an economic evaluation, we consider the resources and the costs on the left-hand side and the outcomes and the benefits on the right-hand side. And so you can see midway down the resources cost side that we estimate that it's costing roughly $120 for each patient in the ED who's seen by a physiotherapist. Now, it's much more complicated to estimate the cost of an ED physician seeing equivalent patients. So to inform that, we may need to undertake a time and motion study. To observe any differences in image ordering, we could undertake an audit. And there are also issues around, well, what's the impact of funding for SALHN as a result of some of these changes? So there's some remaining issues, but it's certainly on the face of it, it would appear that it's unlikely that it's costing more for patients to be seen by a physio than an ED physician. And on the benefits side, we've seen that we've analyzed differences in representations to the ED and subsequent admissions and found no difference. So we feel that an assumption of equivalent patient outcomes, also drawing on the existing literature, is a reasonable assumption. And so the benefits in terms of health system capacity is the reduction in time in the ED. So currently, ED physios are seeing around 100 patients a month. So it's 123 hours are being saved per month. A lot of the benefit or the value of that will depend on where those patients are sitting. If they're in an ED cubicle, if we can save that time, that's clearly more valuable than if they're sitting in the waiting room. So that needs some more investigation. And in terms of reduced inpatient admissions, you know, it's only around 4 per month, but that's 4 occupied bed days per month. And with expansion, you know, that could increase to maybe 12 or more occupied bed days per month. So what's the value of that to SALHN? That also needs to be explored. So in summary, just to really return to my spectrum of evidence, that our feeling is that we shouldn't be at the extremes of that spectrum, and that we're exploring ways in which local data, local knowledge and experience can be synthesized with local interpretation of published evidence to inform local economic evaluations. So I'll stop there and hand back to, I would say the picture there was keeping the baby in the bath is the analogy there.
Thanks, Jon. That was fantastic, and it's, you know, obviously really interesting work working with local health districts, and you know, I think your team is doing fantastic work to try to embed better decision-making processes. Now I'd like to introduce Associate Professor Yvonne Zorinsky, who will speak about the importance of embedded evaluation to support health system sustainability. But I just want to remind everyone who is on the webinar to please submit questions, and we'll be running through those questions once Yvonne has finished her presentation. So over to you, Yvonne.
Thank you very much, Henry, and thank you so much, Jon, for setting the scene. I'm just trying to figure out how to share my screen. And we should be good soon, I hope. How's that? Yeah, we're sharing. Okay, fabulous. Okay, well, thanks very much for that introduction, Henry. And it's been great listening to Jon. And we're talking about evaluation. And I think in the title, it said post-implementation evaluation is the topic of my presentation. Actually, I think evaluation needs to happen from the get-go, even from the co-design stages. So I'm going to go through some slides just to show you where I'm coming from and what my thinking might be around that. So my presentation is going to centre obviously around health system sustainability, since I am the Associate Professor of Health System Sustainability at Macquarie University and at the PCHSS. But I've done quite a lot of work in integrated care, and particularly in developing models of integrated care and evaluating models of integrated care implemented into the health system. So I'm really interested in implementation and evaluation, outcome evaluation, but also the process evaluation, which is often more challenging. And I'll show you some real life examples. I'll talk about lessons, and I'll then talk about potential improvements that we could be making. Are we okay? Okay. I have my team with me here and they're looking at me strangely. So just checking in that it's all okay, and it seems to be fine. So I would be remiss if I didn't define what we loosely mean by system sustainability, and it really implies that the health system endures and adapts by ensuring limited resources, physical, financial and human, are used efficiently and responsibly enough to continue to maintain or improve population or individual health and well-being in a constantly changing external environment. And I think that bit is really important. So Jon talked about contexts change, and contexts change from geographical area to geographical area, but they also change over time. And so systems need to respond. Our systems are challenged constantly by many, many things. There are new technologies being developed. There's, personalized and precision medicine. There's new models of care. There's new diagnostic. There's innovative therapeutics, big data analytics and biomedical technologies. They're all being thrown into the health system. And meanwhile, the system is being squeezed by external pressures, so aging population and rising costs and dynamic federalism and limited resources and changing consumer expectations. They increasingly want to get good quality care, and so they should. And yet, over the last 30 years or so, and you can look at Jeffrey Braithwaite's work, 10% of what we deliver in the health system actually causes harm. 30% is waste or low value care, so it's care provided that has very little benefit to the patient, and 60% is evidence-based care, which actually has effect. We should really be thinking about shifting that equation and moving the 60% up while moving the 30% down. One of the ways that has been suggested to address this is to look at integration of care and to start looking at patient-centered care a little bit more. And the OECD certainly in its framework suggested that integrated care is potentially one of the solutions. And of course, New South Wales Health and many other health systems in Australia have started developing and implementing models of integrated care, particularly to deal with patients who are living with complexity, have chronic, complex or unusual conditions. And so the International Foundation for Integrated Care has developed a model for the implementation of integrated care. And here it is, and it looks beautiful and stepped and lovely, and it all looks ordered and wonderful. And, you start with diagnosing what the problem is, you try and analyze that, you try and figure out a solution, you implement, and then you evaluate. I would challenge that. I think you need to do some formative evaluation. In fact, quite a lot of formative evaluation at the beginning as you're diagnosing and as you're developing and co-designing, and also throughout the whole process of implementation. There are very few solutions out there that are perfectly formed. And so we really need to not be throwing out that baby out with the bathwater and looking at, how we can adapt the solutions that we come up with and how they respond to the contexts and changes within the health system. And our health system looks kind of like this. It's not a simple ecosystem. So this is just looking at clinical genomics, and thank you to Dr. Janet Long from our team who put this together. And you can see that, patients and patient support groups are kind of there represented towards the bottom, but there's a hell of a lot happening around them. And there's lots of clinicians and systems and data and different institutions, even international collaborations going on to try and improve healthcare. So implementing an intervention into this kind of ecosystem is not for the faint-hearted. And it's not a stepwise, straightforward approach. It's often very complex. So implementing complex interventions into complex systems is challenging. And implementation is a complex activity. It occurs within context, and you really need to understand what that context is. It often depends on relationships and engagements. You need some champions to actually champion for your solution. Networking, negotiations, capacity building, you need the right workforce, you need funding, you need the appropriate governance structures, payment arrangements, and of course, culture and policy are huge determinants of what gets implemented and what doesn't. So all of that really needs to be considered. And the reason for that is so we can figure out whether we invest, disinvest, continue, discontinue, or alter solutions that we come up with. So we need to know the reasons why something worked or why something didn't work, not only that it worked or it didn't work. So that's kind of how I conceptualize this. So you need to understand the processes that go behind implementation. And as I said before, I think implementation and evaluation go hand in hand. There's no separation between the two in my mind, really. Frameworks often help to conceptualize what needs to happen and can guide the activities of implementation and evaluation. This is one of the frameworks that we have used, which includes implementation and evaluation and looks pretty much at, you know, the characteristics of the intervention, the inner setting, the outer setting, the individuals involved. If they're not on side, it's going to be very difficult to implement, and also at the processes. So how are we going? How are things being sustained? How are programs being sustained? We did a review of the literature looking at the sustainability of programs, improvement programs in healthcare. And as you can see here, most of them were evaluated less than 12 months after they began. Only a handful were evaluated 5 years or later. And so it's really difficult then to figure out, well, is this sustainable or is it not? And so what we get is pilotitis. I don't know whether you've all heard about this, but it's been talked about for a long time. So it's lots of pilot projects, and many of them don't end up going anywhere because they're not evaluated properly and they're not evaluated in the long term. And this has been a problem in the health system in terms of, you know, funding pilots for 2 years or 3 years. And then there's a failure of continuation. And in some cases, we do throw out the baby with the bathwater. And in other cases, we keep stuff that isn't working anymore. We keep it going because there's no evaluation. So it's really important. So I think I mentioned this before. I think, you know, you really need to be evaluating from the co-design stage, and you need to be evaluating all the way along in order to optimize what you're actually implementing and how. So formative evaluation is really important for scaling and spreading. And you need to do mixed method studies for this kind of work. So you really need to understand the context, and you need to understand how people experience these new interventions. So it's a matter of using both qual and quant. A quick example. So I worked with the Sydney Children's Hospitals Network on the evaluation of their Kids Guided Personalised Service, which is an integrated care service. And it was developed for children who are living with medical complexity. So whether they have a common condition like asthma, but their asthma is not being controlled for one reason or another, or they have a super rare condition and they need, you know, lots of different teams looking after them with 30 health professionals involved in their care, both of these children need care integration. The hallmark of this particular project is exceptional formative evaluation that the Sydney Children's Hospitals Network did. And so they found that the families found it difficult to negotiate the system. There were psychosocial complexities within the families. Healthcare providers also found it difficult to look after these kids, and everybody found the system quite fragmented. And the service culture was very siloed. So they tried to address that by developing a complex intervention that wraps around the child, that involves the family directly, and includes a community lead, a lead at the hospital, as well as a family lead. So the intervention was complex, it was multifaceted. They used routine data to identify kids most likely to benefit. They were assigned a coordinator. They tried to get care closer to home. They used telehealth. They used an app that the family could actually use where they could store their shared care plan, etc. And we evaluated it from the patient, the provider, and the system point of view. And we found that indeed it had benefits for all of those sections of people and systems that interacted with the intervention. So about 2 million per annum were saved in hospital encounters alone. The providers were mostly satisfied, and the families, there was societal benefits for the families, less travel and less school absences as well. So the keys of success was really that formative evaluation. It was understanding what families and patients and providers and managers needed in addition to academic evidence. So it's actually putting those two things together to figure out what is actually needed in this particular context. And of course, they built in evaluation from the very beginning, which was fantastic. So that helped them. I'll go back. And indeed, this model has been sustained and it's being rolled out into rural areas now. The other example is the Lifespan Suicide Prevention Program, and I'll just run through this very, very briefly. So this was developed by the Black Dog Institute and very much grounded into evidence-based interventions. And they came up with a complex intervention with 9 strategies to prevent suicide. And they tried to implement it into 4 different areas of New South Wales. They wanted it evaluated, and we came in sort of towards the end of the implementation cycle, so we were not involved at the beginning. And we wanted to do a more of a participatory evaluation co-design, so we actually co-designed the evaluation. And evaluation should not be an inquisition. It should build capacity among stakeholders. So that was our approach, to work with them rather than just study them like something in a petri dish. So one of the things that really shone in this implementation was the development of networks. And you can see some network diagrams here. Again, many thanks to Janet Long. So these are existing ties, and these are additional ties. And at the end of 2 years of implementation, in all of the sites, all 3 sites where this was possible, showed additional network development. And that was valued really, really highly by everyone involved in the implementation. In terms of you know, how it all went, it was a really stressful time. Everyone said it was a stressful way of implementing. The planning was very limited, and they felt like they were laying the turf, the road, while driving on it. So it really needed that formative evaluation, and that was the missing link in this particular intervention. So it's really, it's not clear what will be sustained. Certainly the 9 strategies were not implemented according to intention. And so certain strategies will be retained, but others will not. So it's never too early to think about evaluation. And I just want to remind you that there is no such thing as a perfect intervention. And so I think we need to be prepared to evaluate as we go, and adjust to context so that we don't throw that baby out with the bathwater. In terms of blue sky thinking, and what I would really like is engaging with partners, fund evaluations. It's often an afterthought, and publish evaluations, particularly those in the health system. Sometimes, you know, the evaluations are not visible to the outside world, and so people make the same mistakes. And publish both your successful and unsuccessful evaluations. There's lots of people to thank. These things always take large teams and lots of collaboration to achieve. So I really want to thank everyone from the SCHN, Black Dog Institute, and of course PCHSS and AIHI. All right, and I'll stop there.
Okay, thank you very much, Yvonne, for that. That was fantastic. And I must apologise, I inadvertently missed your biography at the start of your presentation, but I think everyone can fully understand that you're doing some fantastic work in integrated care models of care delivery. So I mean, I'm very familiar with your work, and I think it's great. So
that's fine. Thank you.
So we might just open it up to questions. I mean, we have a couple of questions that are coming through. Actually, questions / comments, and we have one comment here that says, "Thanks so much for the fantastic presentations." I might just ask my first question while people start thinking about questions of their own. But it seems to me that obviously we work in a complex environment, both within implementation science and also economic evaluation. And Yvonne, you've got a wish list at the end there, which you would like to occur. Can you tell me, Jon and also Yvonne, how do we embed research into policy? How do we embed research into clinical decision making? Because we can do the research and we can do the evaluations, and we often like our own results and we see the importance of that. But how do we convince others that our research matters?
Do you want me to go first, Jon?
If you like, yep.
Sure. Okay, so I think involving policymakers and managers from the get-go and making sure that we're addressing, policy issues that they are concerned about is really important, and keeping them in the loop along the way as well. So it's, it's just not just a matter of implementing, evaluating, and then feeding that back and hoping that something will happen. You actually need to do quite a bit of work. And again, that takes time, and it takes engagement and building of trust between the sectors. We're moving more and more towards embedding researchers in the health system and embedding evaluators. And of course, Jon's embedding health economists, which is wonderful. And I think that's one of the ways of doing it, actually having that conversation at the very beginning, and having a vision, a shared vision, and accepting the results that come out of these things and acting on them is really what's needed.
And I completely agree. I think I'd just add that having that pathway to decision making kind of from the start is what we've found to be important. So as I mentioned, we're actually presenting the results of one of our evaluations to the hospital executive tomorrow. So they bought into it from the beginning. So previous work we've done evaluating health services, I mean, essentially you finish, you publish, and you move on. And there was no kind of link into the decision-making process. So I think in future, my philosophy will be only to get involved in local economic evaluations where there is that link to a decision-making process in the local health service.
I mean, do you think that decision-making process needs to change somewhat?
Yes. Short answer. I mean, so working with SALHN, one of the areas they've asked us to really look at is their process for assessing business cases. So they've received since this financial year, they've received almost 140 business cases, and each of those, not all of those business cases, but a significant proportion of those business cases will be requesting additional resources for new services, new technologies, etc. And so they have requested help in terms of how can economic evaluation be used to improve the quality of the business cases that are being submitted, but also to inform how decisions are made on the basis of those business cases.
Henry, there was a question about what is an embedded research and what is embedded economist, as opposed to an employed.
Yes.
That's a really good question. Oh, someone's got a dog. It's someone who is part of the team and is involved with the team, who is actually making decisions and is, you know, developing solutions and making those decisions. So they're in the process itself. They're not just an employee who does the evaluation. They are actually, you know, embedded with the decision makers and with the people delivering the improvement, the change.
I mean, I agree, and I'd just build on that to say that I think, from my perspective, it's the link between, when in my case, academia and the health service. So you've got someone who's working with the health service, but they've got a whole bunch of resources they can draw on. In this case, Flinders, but it could be any university.
Okay. Jon, I might ask you a question because it's been sitting there for a while, and it goes to your case study 3. Was there any assessment of unplanned representations in case study 3?
Yeah. So that's we did look at unplanned representations and subsequent inpatient admissions, and found no difference essentially between equivalent patients who were seen by the physios or the ED physicians.
Okay. And I know that we're close to time. We've only got a couple of minutes, but I'm going to ask a question for both of you. Obviously, you both work in a complex environment. Jon, your background is mostly health economics, whereas Yvonne, yours is mostly implementation science and integrated care. How do we learn from each other? How do we learn? How does economics learn from implementation science? How does implementation science learn from economics? And apologies for the dog.
There's a lovely dog. There's no doubt. I think we need to work a lot closer together. I think we bring complementary skills to the evaluation and implementation space. And we are doing that through the PCHSS to some extent. We're trying to develop that, those collaborations and actually looking at interventions from multiple points of view.
Yeah, I'd say that I think researchers and individuals with experience in implementation are key people to inform that process of interpreting published evidence in the local context, so they'll have insights into, well, given the intervention as evaluated and given the local context, what are likely to be the issues in terms of implementing this evaluation in this local context, which is a key input to any economic evaluation. Okay, well, our time is up. So thank you very much, Jon, and thank you very much, Yvonne, for your fantastic presentations. I just want to remind everyone about the April webinar on health service evaluation. That'll be happening in a month's time. This recording will be up on a YouTube channel, and answers to remaining questions will be on the PCHSS website. So thank you for your attendance. Thanks, Henry.
Thank you.
Thank you.